Hi, I'm Brad Power, and this is the Cancer Patient Lab. This is our weekly webinar series, and we're honored today to have Jordan Tishler with us to talk about cannabis and its use in cancer. I ran into Jordan at the ASCO conference a few weeks ago, and I was, very curious because Jeff Dwyer had been talking about using cannabis for his palliative care and pain management. And we struck up a little conversation. It was only when I went back and entered his information in my calendar that I realized that we'd met before, and that I had gotten early in my cancer diagnosis around 5 or 6 years ago. He had gotten me medical use of cannabis for my care. So actually, we'd met before, and I didn't know it or didn't recall it. So this is just a quick few housekeeping items before we get started. As always, this is for information purposes only. This is not medical advice. We try to arm our patients with information they can take to their medical team. Second, everything that will go on here will be made public. So if you're concerned about your image or your name or anything you say being made public, you can hide your image, change your name, and don't say anything. And finally, we are a 501c3 nonprofit, and we depend on the kindness of people making donations. So we would welcome your donations, which is easy to do by going to our website and clicking on the donate button. With that, I'll turn it over to Jordan.
Well, thank you. That's a lovely introduction. It's nice to see all of you today. I'm going to pull up some slides and just use that to start, but that's certainly not going to be the main thrust of our, well, it would help if it actually were behaving. Maybe I need, yeah. All right, let's try that again. There. All right. So before most of you hopped on, I was saying that this is a slide deck that I use for a lot of given talks, and it's typically kind of 45 minutes worth of material. So I'm not going to go through all of it, and just sort of we'll start out a little bit, and then we'll have you guys ask questions and kind of go that way. So really, this slide here is the one that I just want to spend a little time on so that you kind of understand where I'm coming from. So yes, I went to Harvard Medical School a long time ago. I trained in internal medicine at the Brigham and Women's Hospital. And then I didn't practice internal medicine, but rather actually went into emergency medicine and spent about 20 years doing that. The last 15 or so of them were for the VA Medical Center. For those of you who are in the Massachusetts area, the one in West Roxbury on the VFW Parkway. And it really was sort of through that experience when Massachusetts started talking about medical cannabis. I think, like most of my colleagues, I said, medical what, right? But unlike many of my colleagues, I had really seen a huge number of veterans in that ER who had really been harmed by alcohol and maybe a smidge of some other drugs, but really alcohol was the main issue. And it led me to think, I've never really seen anyone terribly sick from cannabis. So if it's not terribly toxic and people seem to think that it holds some therapeutic benefit, maybe I should learn something about it. And, at the time, we're sort of talking about 2011, 2012, people were running around sort of on the political side, like Mrs. Clinton, saying, well, it's a nice idea, but there are no data and we can't really support that and whatever. So, at that time, if you went to PubMed and put the word cannabis in, you would only get about 25,000 studies. So the issue at that point was not that there weren't studies, but rather that there was such a mess of studies that it was very difficult to figure out what it all meant and what you could do with it. So thereupon ensued several years where I marched my way through this insane literature. And I really came away from that convinced that cannabis can be used as a medicine and that, like any medicine, it has risks and benefits, and that if you use it carefully and wisely, you get the mostly benefits. And if you use it poorly, then you're more likely to get some of these more negative outcomes. Um, that process led me to form my private practice, Inhale MD. And from there, I recognized that most physicians really didn't have this knowledge and were not be able to guide their patients. And in fact, many of them were so ignorant as to say, I don't know anything about this. I don't want to talk about it. So that led me to form our not-for-profit, the Association of Cannabinoid Specialists, which is really focused on educating clinicians on how to do this well and carefully, as well as to influence policymakers to improve the systems that we have, which frankly are pretty lousy. And I always mention I don't have any conflict of interest that we should talk about. This slide is about symptoms, right? And almost all of these symptoms apply in this situation where we're talking about cancer, right? So we've got pain. What we know about cannabis and pain is that it is a reasonably good, not brilliant treatment for pain. And that if you pit it head to head with the opioids, it's about equal for mild to moderate pain, meaning non-surgical pain, and that in fact, it gives us a whole nother set of options before we get into opioids, so that many patients might not need opioids at all. Even those who do need opioids will need less. These are documented by studies. And patients who start out on opioids often can have their opioids reduced somewhere between 40 and 80% when we add cannabinoids into their regimen. And it's important for us to understand that the issue here really is that opioids may be effective, but they come with significant risks, and the risks associated with cannabis are not zero, but they're less than those of opioids. And so we'd rather use the cannabinoids rather than the opioids if we have that choice, or less opioids if we need any at all. Anxiety and depression is a huge issue for many people, including those people with cancer. I think this is a really important topic to mention, at least briefly, because this is an area where what we know are best practices is very different from what people out there in the community will advise people to do. So if you ask somebody who has been using cannabis for a while how to treat their anxiety and depression, you'll get a story that's similar to, well, when you wake up in the morning, you smoke up a big bowl of weed, and at any point you feel kind of low or anxious, then you just keep smoking. And we know that that's not a very good approach. Number one, we know that that intoxication often interferes with people's goals for the day, whether that's work or school or whatever they have to do. But the second and perhaps larger issue is that at higher doses, cannabis can actually provoke anxiety and depression. And so you can end up in this vicious cycle where you use it for anxiety and depression. You actually end up feeling better in the moment, but longer term, meaning over the next couple of days, you feel worse, and then you use more, and you can get caught in that cycle. It turns out that for treatment of anxiety and depression, low doses, typically given in the evening or before bed, are much more effective. And to me, very interesting, because what that says is that if you're taking some cannabis and it causes the intoxication, which I tend to look at as a side effect, but then you go to sleep and sleep it off, the anxiety and depression benefit persists throughout the next day without that intoxication. And people get very focused on sort of the intoxication, which for some people is very pleasant and other people not so much. But really what's interesting to me is the fact that what it's really doing is some neurochemical changes that allow us to get the benefit to anxiety and depression without the intoxication if we're using that kind of a dosing regimen. Insomnia is a huge issue. There are different types of insomnia. People have trouble getting to sleep. Other people wake up too early. Some people have all of the above. The approach to those issues depends on sort of what that constellation of or pattern is. But I think that of all the things that cannabis can treat, it treats insomnia best of all. I'm going to lump 4 and 5 together, right? Anorexia in this case does not mean anorexia nervosa, but rather just poor appetite, which is certainly something that we see in folks who have cancer or are getting cancer treatments, as well as the nausea and vomiting. And it turns out that, we don't have a lot of great medicines for the appetite issues. Cannabis is probably the best thing for it. Whereas on the nausea and vomiting side, there is ondansetron, which is also called Zofran, which is generally, I think, better and doesn't have as many side effects. But again, it's not an either or proposition, and certainly they can be used together, and that is often a combination that gets us sort of across the finish line. And then sexual dysfunction is on this list. Cannabis can be a very effective treatment for both males and females across a broad range of issues. This happens to be my area or one of my areas of research. And so I won't spend a whole lot of time on that unless you guys have questions. And that all being said, I'm going to put the slides away and we can get on to those questions.
Okay, I'll help moderate. We can submit questions through the chat or use the raise hand feature. For those of you who have any questions, either use the raise hand or submit them through the chat. There we go. Russ raised his hand. Russ, what do you got?
Right. I was just wondering if you had looked into psilocybin or bufo.
I know a fair amount about the psychedelics and the psilocybin MDMA in particular. It's something that I have decided not to focus on particularly, though I'm involved in some of the political discussions. Did you have a more specific question about psilocybin, that I could potentially address?
Yeah. For cancer, pain, anxiety, depression, whatever. Kind of like maybe Jeff's situation a little bit. Are psilocybin or bufo, are they perhaps stronger than marijuana or CBD or weaker or not as well studied?
I think that we don't have much data on those drugs for pain management, particularly. And in fact, if we're thinking about sort of non-classical psychedelics, ketamine is more readily available because it's not illegal at the moment and has a much stronger track record for pain management. And I have used ketamine orally for some of my cannabis patients when they needed an adjunct to cannabis. So I think that if you're thinking about sort of what's the next step beyond cannabis, I would say ketamine is probably the thing where it is most readily available and has the best literature behind it. The more traditional or classical ones like psilocybin, MDMA, LSD, the research there is more focused on the anxiety depression side than on the pain management side. And I think that the evidence we have now, which is interesting because much of this research is just repeating stuff that was very successfully done in the 40s and 50s. But needs now to be, redone, has shown a tremendous success rate with anxiety, depression, alcoholism. But the key, and this is one of the things that is not being understood in the sort of public context, is that taking the medicine is not effective. It is only in the context of psychotherapy that it has an interval of medication-assisted psychotherapy that we see these kinds of positive results.
Hmm. Okay. So would you suggest ketamine, Jeff would look into maybe if his pain got worse, ketamine in addition to CBD or in place of it?
So there's no reason to think of it as a replacement. They're perfectly fine together.
Hmm.
Um,
Okay.
you know, if I were seeing Jeff and counseling him, I would probably say, let's make sure that your cannabis or cannabinoid um, regimen is optimized as much as possible before we go seeking alternatives or additions. I think that's generally a good practice. But assuming that we had things as well in hand from the cannabis perspective as possible, then ketamine would probably be my next suggestion.
Okay. All right. Thank you.
Um, I want to springboard from there for a second and go back to some of the things that Jeff said before we formally began. And I want to say two things. One is hemp, right? And maybe everybody knows this, but hemp is just the same plant as cannabis, right? There's nothing different about the plant except that hemp has been bred to produce very little THC, right? So the way I think of it is they're all roses, right? But we can breed some to be yellow and we can breed some to be red and some to be black if you're really, into golf. Um, but they're all the same plant. And so what we have done in our country, which makes no sense at all, is that we have defined these as two separate things because one has THC and the other has everything else, but not the THC. So then we've moved forward with regulating cannabis with THC on a state by state basis, and we've kind of done a really crappy job of that. But one of the few things that we can say about the state legal cannabis products is that they are all safety tested, right? And so they're regulated at the state level. States have different standards. Most of them are pretty good, but they do have standards for testing. And then we got hemp, which was legalized, some say by accident in 2018 in the Farm Bill. And there was no follow-on regulation at all. And so no hemp product meets any standards whatsoever. And this means that those hemp products, through research, we know are often filled with pesticides or heavy metals. Um, and um, and so that's one set of problems with hemp. The second is, of course, that because the hemp plant was then allowed to make CBD, enterprising companies and their scientists, and I'm going to put air quotes around scientists, have figured out how to convert that CBD into a whole range of other cannabinoids for the purposes of being intoxicating. So we've got Delta 7 and Delta 8 and Delta 10 and HHC. And the point is that fruit salad of acronyms can go on forever. And what we know about these molecules is very little. So to me, the issue with hemp is not simply whether the cannabinoids are intoxicating or not, but rather what do we know about those chemicals in the human body? Do they cause cancer? Do they cause birth defects? Do they cause heart disease? Right? Most of these chemicals, the answer is we don't know because they're new and we haven't had a chance to study any of them as compared, for example, with Delta 9 THC, which has been studied since, effectively since 1960, and obviously has been used in great abundance by lots of people for a very long time. So my advice to folks is not to buy hemp-based products, but rather to buy state legal products where they can, because they are held to these scientifically based safety standards. And certainly to avoid any of these, novel chemicals that are being introduced, the laundry list I just mentioned. And then the other thing that I would mention is that CBD has become very popular, largely because everyone says, well, maybe it's medical and it doesn't cause any intoxication, so isn't that wonderful? The thing is that a lot of the things that people say CBD is good for are based on rat studies, and none of us are rats. It turns out that of medications that work in rats, 92% of them will fail in human beings. So what we have looked for over the past 5 to 10 years are translational studies that demonstrate that the findings that look positive in rats actually work in human beings. And we can have a few studies that show that at extraordinarily high doses, meaning 300 to 600 milligrams of CBD, we can show some anxiety benefit, typically not generalized anxiety disorder, but rather, what people call social anxiety, which is sort of stage fright. But when we look at it for sleep, it doesn't seem to pan out. When we look at it for pain management, it doesn't seem to pan out. By and large, I think the whole CBD discussion is a way of trying to sidestep the issue that the THC is largely what we know is an effective medication. And then there's a smattering of other cannabinoids about which we don't know very much just yet, that are freely available on the market, in the market, as a way to sort of differentiate product. But again, we really don't know enough to be able to say, oh yes, you need X milligrams of THC plus CBG or any number of other things that we could throw in there. So at this point, my advice typically focuses on the THC element. And I also would point out that CBD specifically, more so than any other of the cannabinoids, can interact with conventional medications, which may interfere with things that are significantly dangerous, like heart medications like amiodarone, anti-rejection medications like tacrolimus and everolimus, blood thinners like warfarin, and surprisingly, good old Claritin. And Claritin in overdose can cause fatal heart arrhythmias. So, I just think that we have to pay a little bit of attention to those risks before we decide that CBD is, all that. So
Thank
that
you.
was a long thing.
Yeah.
That we've gotten a few more questions come in since then.
Yeah. Vanessa's raised her hand and then we'll go to some in the chat.
Hi, Vanessa.
Hello, I just have two quick questions. Can you just speak for a minute on pharmacodynamics and specifically blood-brain barrier penetration between different formulations? So, for example, like if you were doing one-to-one CBD THC, taking a pill versus the sublingual oil versus the oral mucosal sprays. That was my first question. And then my second question was, there's a lot of talk in the brain cancer. CBG is kind of the new exciting thing. So, do you have any thoughts about that specifically in brain cancer? And whether you do or not, who would be the best resource on that topic?
Okay. That was a lot of good questions. So let me see if I can address them all. So generally speaking, bioavailability is fairly variable and fairly poor, particularly through oral ingestion, and that has led us to a lot of discussion of other similar routes of administration. It turns out if you take a well-made oral preparation, a gummy or a capsule or something like that, that you absorb about 15% of it. And so that's not very good in terms of sort of cost effectiveness, but in terms of effectiveness, it's fine. And so I tend not to worry tremendously about that. Only, I tend to be focused on just we need to get enough in. It doesn't matter if some of it is not being appropriately absorbed. The oral mucosal sprays are interesting. There's really only sort of, two such products, right? There's Epidiolex from Jazz Pharmaceuticals, and then not in the US, but elsewhere, there is
Nibixinals, yeah.
And The thing I think that's important to understand about those is those are really pharmaceuticals. And the reason I say that is the way that their effectiveness is dependent not only on the active cannabinoid ingredients, but also on the inactive, what we call excipients, other substances that are in there very specifically to cause or allow the cannabinoids to pass through the mucous membrane. So normally speaking, our mucous membrane is designed to keep things out. We don't normally absorb things through our mouth. And so to make those things work, they use a combination of oils and various types of alcohols to actually break down the barrier in our mouth. And those medications are effective in that translocation. However, two things. One is the number one reason people don't use or don't continue to use it is because they get a sore mouth, which is not unexpected, but it's unfortunate. And the other is that when you then see other forms of cannabis products, particularly at a dispensary, that talk about sublingual administration, those are not the same thing. And it's really important for us to understand that when they talk about sublingual or buccal administration, they're generalizing.
Is everybody else experiencing that he stopped?
Yes,
Yep.
yeah.
Yes, I am.
Okay,
Yeah.
that's unfortunate.
I guess you had too much cannabis.
There we go. You're back.
Can you hear me now?
Yeah.
All right. Well, my power just went out. So my laptop and my phone are what we're using, and it may die again, but I think they're fully charged at least to begin with.
Good.
So I was starting or saying that, there's this generalization from the pharmaceutical products to these kind of artisanal or dispensary products, and that's just not fair. And we have really good data that show that if you put a cannabis oil under your tongue, people will believe because of sort of what we call classical conditioning or Pavlovian conditioning that they're getting the intoxication effects, et cetera. But if we actually measure their blood, there's nothing in there, right? And what happens is eventually they'll swallow that mouthful of stuff and then it'll get absorbed through the gut normally. So for that reason, I tend not to recommend sublingual dispensary products because I think that they're not more effective. And the other thing is that dosing is hugely important. And when patients typically come to me and they're using some sort of a tincture, I'll say, okay, well, what's your dose? And they'll say a squirt. That doesn't help me help them, right? So, whereas if you're using a capsule or a gummy, there is a stated and measured amount in there. So if you take a 5 milligram THC gummy, or you're supposed to, then the question is, did you or didn't you take it, not how much did you get? So I think that there is some advantage to using these discrete objects to help us communicate what it is you should be getting and how much you should be taking, et cetera. In terms of the translocation across the blood-brain barrier, our evidence to date is that THC translocates pretty well. There are some terpenes that may be helpful, but that's never really been tested in the context of cannabis. So, for example, humulene and linalool are terpenoids that assist with the migration of other drugs across the blood-brain barrier. So it might stand to reason that they would help with cannabinoids, but we've never actually done that study, so I can't give you a straight answer on that. And then I think the last part of your question was, what do we know about CBG in the context of brain cancer? And I think the answer there is absolutely nothing of use. And that my feeling about CBG is that it likely will turn out to be very useful and very helpful, but we've done almost no studies on it at all. And So I would kind of put it in this really kind of weird middle ground where I wouldn't say, oh, don't use it or you have to be really cautious, which is what I would say about CBD. Um, but I don't think I can put it in the category of this is a good thing, you should definitely use it. I think it's probably not harmful and it might be helpful. We just don't know. And I'm
Thank
afraid that we don't know is the answer to a lot of the questions. Um, and in some ways, we don't know still leaves open the question. Well, so if we don't know, should I do it or should I not do it? And I think the answer to that is somewhat about risk tolerance on a personal level. Um, but we should at least acknowledge that if we're going to do it, we need it to be from a safe source. And again, getting back to the hemp side of things, that's not generally a safe source for us. All right, next questions?
thank you.
Thank you, Vanessa. Chris Apfel, you've got a question in the chat and you're on here live. Do you want to voice it yourself?
Sure. Yeah. So thank you for the presentation. I was hoping that you would also be able to show some data in terms of what's known in terms of cell-based or animal-based assays, but also in terms of clinical outcome studies. And I'm currently now going through the literature on the Aristocrat trial that actually started in Birmingham that you may be aware of, Birmingham, the UK, actually where I studied for a year at the Queen Elizabeth Hospital, and they have actually shown that adding cannabinoids to patients with glioblastomas that were under temozolomide did actually have, in the phase 1 trial, did have a longer life expectancy, and they are now in the phase 2 trial, and so I'm currently looking into what are the clinical trials that actually do stuff, and one of the reasons is we have actually added it into our Sage Oncotest repurposed drug panel, because we actually can sometimes see on repurposed drugs treatment effects, cytotoxicity or antiproliferation for the different substances, but they vary tremendously from patient to patient. And so that's the reason why we believe it's actually really important to test the substance, because it may or may not work. And do you have any evidence in terms of clinical effectiveness for any of cannabinoids on tumor response? Because many tumors also have cannabinoid receptors.
So, just for the sake of everybody else on the discussion, I just want to say you have shifted the conversation with that question from symptom management to tumor treatment. And I think that's a perfectly reasonable question, of course. But my point is I want everyone to recognize that we've changed the conversation a little bit, because the data we have are really about symptom management. And when we get into your question area about anti-tumor efficacy, the answer there is we have almost nothing in human beings. Now, I would point you to a whole body of literature that has been done by Professor David Merri, Meiri, in Haifa, in Israel, who's really the leader in this field. And he's working in cell culture. But what he has found is very interesting, is that in the cell culture, he has found that different cannabis extracts containing different cannabinoids are cytotoxic to different tumor lines. So there's specificity between the type of tumor and the type of extract. We know from previous studies that both THC and CBD are cytotoxic. But what's interesting is if there's specificity and all of the cannabis extracts have THC and CBD, then that specificity is relative to something else in that extract. And so he's working now basically doing fractionations to figure out what are the elements that are creating that specificity. And ultimately, it is my belief, and I expect it's Professor Merri's expectation as well, that from this we are going to narrow down these extracts from, whatever is 140 odd cannabinoids down into a pool of maybe 2, 4, 8 cannabinoids that are relevant and perhaps specific to certain markers, tumor markers. And then we'll be able to package them essentially as a pharmaceutical that has the kind of activity that we're looking for. But those, that's the aspiration. I don't think we're there yet.
Right. Yeah, I would love to continue that conversation with you and with him. Perhaps we can have a three-way conversation offline. But I also wanted to comment on your argument on cell line work and mouse models. And you made this bold claim that humans are not mice, which I think I have a hard time to argue against. But the question is, what evidence does it provide? Because many of the mechanisms and a lot of the biology between a human and a mouse is actually pretty similar. That's the reason why we use mice as models. Most mice have brains, have hearts, have lungs, and the function is pretty amazing similar, and even the behavior. But apart from that, let me try to make the key point. When you actually in the drug development, one of the things is that most people are working with cell lines that double every 24 hours, as opposed to a patient's tumor who basically doubles in size every 90 days, every 180 days. The biology of cell lines versus a patient's own tumor is very, very different. And one reason for the failures in drug development is actually not because the mouse is not a human. The main issue is that they're using cell lines, whether in vitro or in the mouse. And the cell lines actually behave very different to a patient's tumor. We have very good evidence that when we take a patient's tumor tissue, either put it into a mouse or actually create microtumors in our SAGE oncotest, that correlates very nicely with patient outcomes. So, so that's another offline discussion we can have, because one can actually predict with over 80% of accuracy whether a patient's tumor that is exposed to a range of drugs will respond to a therapy or not.
I think that's exactly where we need to go, right? I mean, ultimately, there is this catchphrase which I find somewhat offensive, that everyone's different. And I find that at least in the cannabis world, that usually gets meant to mean, oh, nobody can give you any good advice. You just need to go and screw around with it until something happens. But the reality here, as you point out, is that people do have genetic heterogeneity, and their tumors have extraordinary heterogeneity. And I very much think that marker-driven therapy, which we see even in conventional medicine now, is on point and will only become more and more germane. And so, yes, and ultimately, I mean, there are lots of companies out there trying to look at genetic testing in human beings to guide their cannabinoid use and essentially product choice. I don't think we're anywhere near that yet, but at least, the idea that we could be looking at specific markers of the tumor. Yeah, it's huge.
Coming back to the markers and genomic testing, what we do is actually something different. We actually recreate 3D microtumors that are live. So we are not using biomarkers. We are not using genomic testing, because the biomarkers and genomic testing are based on dead tissue and have strong limitations. We really see how the tumor responds to the treatment ex vivo.
Oh, that's
Yes.
very clever. I'd love to hear more about that. I think, that's fascinating. So you take out a bit of their tumor and then you go out at it in a live situation. I think that's fascinating. Let's talk more.
Okay, will do.
Alexander Lalov, you're next.
Dr. Tishler, excuse my ignorance, but what's the relation? Is there any relation between the hemp that you're talking about and the one that I'm consuming from?
Yeah, you ask a really good question, and it's just more complication and muddying of the waters, right? So we have, where did you go? Zoom keeps moving the pictures around as I'm trying to
He,
look at.
he put his hand down. That's why he's still there.
I'm buying this from Costco, actually.
Right. So that is a food product
Yes.
and may or may not contain any cannabinoids. And those are typically made from the woody part of the plant or from roots or seeds. In terms of what's in there and what has value for you, okay, those are shelled hemp seeds, is what it says underneath the brand there. Those don't have any specific cannabinoids in them. They are high in sort of general flavonoids and other omega-3 type oils, and have been put forward as a dietary supplement. FDA is supposed to control dietary supplements. They have said these do not qualify as dietary supplements, but have not apparently gone after the Kirkland brand or Costco, even though they are clearly in violation of the law. But more to the point is, what is in that for that's of value to you? Probably not much, but it's probably not harmful either.
Okay. Jeff Marchi, you're up next.
Yeah, you were talking about the components of THC that might be useful for different types of cancers, and Rick Simpson oil has come up with a very strong THC that people say if you have to use quite a bit every day, and they don't get high anymore, even though it's a gram of THC. What other people have claimed that their tumors have reduced in size. What do you know about this?
Unfortunately, fair bit. So first of all, Rick Simpson did not have the kind of cancer that any of the people who are thinking about Rick Simpson oil typically have. There's a better example of a woman from California whose name is escaping me at the moment, who said that she followed the Rick Simpson approach and that her breast cancer, which was stage 4, was completely cured by this. And it made a lot of news back around, I don't know, 2015 or 16. And then shortly after, there was this big, news cycle about it. Unfortunately, her breast cancer came back and she died. So I think that, there is unfortunately just this sort of PR machine that picks up these positive stories and then doesn't give you the full truth. Rick Simpson oil, literally following his recipe, is just a simple ethanol extraction. It creates a very dirty product. There are certainly cannabis concentrates that have been developed since then that are cleaner in terms of being more appropriately purified. But the real question is, what do we know, from a scientific point of view about taking these mega doses of THC? And there's really no evidence at this point to support this method. Certainly, there's lots of anecdotal positive stories, but the problem again is we just don't have that full context. Taking a gram a day is an extraordinarily large amount. Certainly, none of the preclinical studies, the mouse and cell culture models, suggest doses that high. The idea that you won't get high after a while sounds like the good news, but it really isn't, because that is in fact demonstrating that you are fully dependent on it and that stopping it will create all manner of problems, withdrawal symptoms. Essentially, what happens, and this is not specific to the Rick Simpson model, is that if you take excessive doses of THC, your brain and other tissues sort of takes away the receptors, right? It says, why are you shouting at me? Oh, I got to turn down the volume. How do I do that? I take down the receptors, little microphones, right? The problem is those microphones aren't there for THC. They're there for our internal signaling processes called our endocannabinoids. And if those receptors then get taken down because you're flooding the system with THC, then there aren't enough of them to hear the internal signaling. And that's when we get these situations of dependence from high tolerance. And frankly, as far as I can see, there's no benefit to those things and certainly lots of downside. So I wouldn't typically recommend that. What I have, I have certainly advised patients who wanted to take higher doses than we would typically for symptom management. And in those circumstances, what I've typically said to them is to start at a relatively low dose and to work up sort of 5 or 10 milligrams at a time over a longish period of time, meaning many weeks to months. But also then at some point, if the side effects start to be significant, then to stop and hold at that point. And what I found is that most people typically top out sort of between 40 and 80 milligrams of THC and a sort of equivalent amount of CBD, which is very much less than a gram. And I can't say, and this is of course anecdotal because it's not a study, I can't say that I think that I've seen patients taking those kinds of doses do any better than the ones who are taking the lesser, more symptom-oriented doses. So I do think that there is an understandable kind of desire to latch on to this methodology because you've got cancer and that's very bad news, but I think that there's some real risk to these high doses and it can make your quality of life really crappy because you're feeling the side effects all the time and there's just really very little evidence to support its use.
Okay. Len Sierra, I see a note in the chat. Do you want to give voice to it?
Yeah, thanks, Brad. So my question was, is there an ideal consensus on ratio of CBD to THC when used as an anti-inflammatory?
Oh, that's a very complex question. Thank you. So how do I parse this? Let's start with the anti-inflammatory part of it. All cannabinoids appear to be anti-inflammatory in the test tube. However, it doesn't seem to translate into human beings. And so there's a lot of discussion about CBD as an anti-inflammatory based on these sort of non-human observations. But in fact, we've never demonstrated that it is an effective anti-inflammatory in human beings. And another example is THC, which when we give it to people with autoimmune diseases, specifically Crohn's disease, what we find is that their pain goes down and their quality of life goes up. But then if you do an endoscopy to look at the actual state of the disease, we see that there is no anti-inflammatory or disease-modifying changes. Now, that being said, there is another cannabinoid, which is confusingly called THCA, which is the precursor of THC, but it is a different molecule that has been shown to have very strong anti-inflammatory benefits, both in the test tube, where it seems to be about 10 to 20 times more effective than CBD. And we've seen this in actual Crohn's patients modifying their underlying disease. So again, I think that there is a push towards CBD because it's non-intoxicating and it's readily available, but there's really little evidence to support it. If it were up to me, which unfortunately it is not, I would be pushing for THCA, and I do this with my patients because the data on THC are better, or THCA rather, are better. The reason that THCA has not caught on in particular is because if you heat THCA, you get THC. And nobody in political power wants to be approving a medication that you only need to heat in order to turn it into, you know, an intoxicating chemical like the devil's lettuce. In my clinic, where I take care of patients who have Crohn's and who have ulcerative colitis and rheumatoid arthritis, which are three, you know, classic autoimmune inflammatory disorders, adding THCA to their standard conventional regimen has, in many cases, gotten them into a full remission when their conventional medications alone have not. I would never use any cannabinoid as a substitute for those kinds of medications because the data aren't there, but ultimately using it has been beneficial to some of those patients. And again, that's anecdotal. So back to your question about ratios, I would say, look, THC and CBD really just have never been shown to be effective as anti-inflammatories in human beings. So I think that they were sort of barking up the wrong tree. And if I were counseling you, I would say, look, if we're looking for pain management, then we need to be focusing on THC. And if we're looking for anti-inflammatory benefit, then we should be looking at THCA. And I don't think that CBD has the safety profile or human data to justify it.
Just picking up on the inflammatory discussion, Chad Magnuson asks in the chat, does hemp interfere with pain signaling to reduce pain, or is it simply reducing inflammation to reduce pain?
Well, that's right on point, and I would say THC act to decrease pain, probably primarily through actions in the central nervous system where there are receptors, although there are also receptors in the spinal cord as well as in the periphery. So we don't really know where the bulk of the action comes from, but my understanding is that it's probably primarily a central acting medication, which of course, you know, people say, oh, well, maybe we can make a THC that doesn't get into the brain and then it won't cause the intoxication and that'll be wonderful. But I suspect that it will also be ineffective because it's not getting into the brain where that perception is happening. And then, you know, and to the question again, the THC, while looking like an anti-inflammatory in the test tube, really doesn't seem to work in human beings. And similarly, again, the CBD does not seem to work as an anti-inflammatory in human beings. So that if we were looking for specifically anti-inflammatory, again, I would look at that THCA. And I would also say that the data on THCA are much further along than for these other cannabinoids in terms of human studies, but they wouldn't meet any FDA level scrutiny at this point. There's still much more research that needs to get done.
Frank has his hand raised. Frank?
Yes. I mean, I could be pretty radical sometimes. So my education is that I finished the 8th grade. Okay. I dropped out of school in 8th grade. So I was a street heroin addict in New York City in the 70s and until the late 80s. I've been clean off of heroin for 40 years. Okay. I could take a narcotic medically if I have to, but I don't want to. And I do take them and I don't like the feeling anymore. So I tried smoking pot. I mean, I don't know. I'm not a lab rat. Let me just say that. You guys are all intelligent. You got all these degrees and shit. I ain't a lab rat. I'm a human being. Okay, I did the experiment already myself. Okay, that's what I tell everybody. Drugs, well, like I agree with Jordan's saying about going after these you know, I don't even know the Ricky Simpson oil and crap like that. You start going to, you want to get to that degree, you're crazy because it's going to take you to a place you don't want to go. That's the effect of that drug is not good when it's taken at those levels. So I smoke a little bit maybe in the morning to take the edge off, and I definitely smoke some before I go to bed, and that's it. Okay, I'm 65 years old. I'm living with cancer. I got a long life. I just finished Pluvicto. I got a lot to say. But so the thing with me is like, I don't, it's like, for me, it's like I've been in my whole head all my life. I've been like taught that drugs are no good, bye, so I deal with this feeling of like guilt, I guess, when I smoke weed, right?
Yep.
And I could deal with that because I've dealt with way more than that in my life. I mean, I'm 65 years old. I'm going to say my oldest son just retired from a very, very high secure place in the United States Navy. I mean, I got 4 of the kids. They're all college educated. I got 12 grandchildren. I had 2 businesses. So I've been blessed. I gave my life to Christ in 1984. Okay. I was a street heroin addict.
Come
Living in
on.
an abandoned building in the Lower East Side of Manhattan, on the streets. Man, God, now I got a house, like I got a beautiful home, beautiful wife, beautiful family, and I got cancer. So what's the big deal? I mean, it's like you guys are debating like whether or not I'm allowed to smoke weed or not. I think, or what the advantages of it are. I mean, who cares? I mean, like, you smoke some weed and I'm just gonna live with my cancer. I ain't dying from cancers. I mean, that's what I got to say. I mean, I'm just a straight up individual, and all this back and forth about this lab rat, that lab rat. Who the hell cares about the lab rats? You know what I mean? What about us human beings who got cancer? You know what I mean? What about us guys? We're trying to figure out how to get up, how to go to the gym. You know what I mean? How to play this guitar, how to ride my motorcycle, how to play with my kids. Think about that. That's what we should be thinking about. Come on. Jesus, whatever. I'm out of here.
Thank you, Frank. Jordan, we've hit the hour. Do you have any closing words? We can maybe cover with some more of this after we stop the recording, but want to capture any closing thoughts you have or key messages.
Okay, thank you. And I apologize for my dropping out there for a minute. Obviously, the power grid and probably the cell phone providers are struggling today with the heat and whatnot. Cannabis is a medicine, right? And every medicine is a double-edged sword, right? If you use it carefully, you get benefits. And if you use it, not carefully, you can get a lot of negative consequences. And I think that the key for us about to take care of folks like you is to make sure that all of your team members are aware of this as an option, but also aware of how to use it. And so I would just make a little plug for the Association of Cannabinoid Specialists, which is a group that I run. You can go to cannaspecialist.org. And learn more about how we're trying to educate your clinicians. And furthermore, I would also just welcome you guys, if you have further questions, to email me directly. I'm happy to try and give some guidance. And my email is doc@inhalemd.com. And I'm also happy to stick around for a few more minutes offline or off recording or whatever to answer further questions.